Hello, welcome to the International Conference on Women Health and Nursing 2022. I am Isabella Romero Estevez, and I am going to explain my review paper on the use of electric stimulus to treat urinary incontinence. I am a bioengineering student developing my studies at Universidad Politecnica de Madrid in Spain. I wrote this paper with my professors from George Mason University during my junior exchange year. Studies related with women's health are very important, specifically the ones related with illnesses that affect their quality of life. Urinary incontinence is a common issue that markedly affects women's quality of life. There are several types, but overactive bladder is often resistant to various treatments. There are some methods to mitigate or reduce this problem, such as medication, surgery, or exercises. In this presentation of my review paper, I will go over different treatments for overactive bladder. First-line treatments include lifestyle changes, physical therapy, and one electrical method consisting of vaginal electrical stimulation. Second-line treatments such as pharmacotherapy, and then third-line treatments including Botox injections and 2 more electrical stimulus treatments. In this paper, there is a specific focus on the use of electric stimulation, explaining vaginal electrical stimulation, posterior tibial nerve, and sacral nerve stimulation. This is a solution that has a long way to go and more hopeful results to be found. We hope that these findings will contribute to achieving a better quality of life for patients. Even though the process of writing this review paper was long and a lot of references were analyzed, I really enjoyed it and has enhanced my analytic, critical thinking, and writing skills. I hope you enjoyed this presentation, and thank you so much to SciTech Central Conferences for offering the fantastic opportunity to participate in this virtual conference. First, I would like to start with an introduction. Urinary incontinence is a common morbidity with a prevalence of 20 to 30%, more common in women with a 30% in contrast to men with a 5 to 1.5%. It consists of 4 main different types, including stress urinary, urge urinary, overflow, and functional incontinence. Urge incontinence is a manifestation of overactive bladder. Overactive bladder has a prevalence of about 20% in 40-year-old women. It is characterized by urge, frequency, nocturnia, and urge incontinence. It significantly affects quality of life, including increased healthcare visits, high rates of depression and anxiety, poor quality of life, increased falling and subsequent injury, increased rate of urinary tract infection, and reduced work productivity. The estimated direct annual cost of overreactive bladder in the United States is over $50 billion. The treatment for overreactive bladder is mostly conservative, ranging from different medications, physical therapy, and electric nerve stimulation, and injections. The aim of this paper is to review the different treatments for overreactive bladder, focusing on the electrical stimulus. Continuing with the presentation, I would like to explain the first and second line treatments. These are the first options to treat this disease. First, the patient can do some lifestyle changes. They include avoiding caffeinated beverages like coffee or drinking at night, bladder training, and keeping a bladder diary that can be useful to understand the patterns of urination and drinking, allowing recognition of a pattern that can be changed. A second option is physical therapy. Pelvic floor muscle training is the first line used for both stress and urge urinary incontinence. These trainings consist first in an effective pelvic floor muscle construction, lifting the muscles in cranial and forward direction, increasing the urethral pressure and preventing urine leakage. Ultrasonography and MRI have demonstrated the effectiveness of these movements. Women treated with physical therapy reported cure or improvement, better quality of life, fewer leakage episodes per day, and less urine leakage on short office-based pap tests than controls. Another option is vaginal electrical stimulation. It is the first electric stimulus technique that I am going to explain. It is a device allowing pelvic floor muscle training and treatment for urinary incontinence. It consists of a non-implantable pelvic floor electrical stimulation device delivered by a vaginal probe connected to an external generator, as we can see in the figure. The goal is to exercise and tighten or contract the nerves and muscles to strengthen the pelvic floor. The technical aspects of this technique is that the electrodes have to be placed vaginally or transanal, and the electrical current is applied to them with a wire connected to an external simulator battery. The treatment can vary from 20-minute session twice a week to daily sessions. For urge incontinence, the objective is to fortify the inhibitory system by inhibiting neurons that operate at low frequencies. The stimulation is administered at 5 to 20 Hz. For stress incontinence, the goal is to activate the motor neurons, so it operates between 20 and 50 Hz. And for mixed incontinence, it can alternate between the two ranges described. With this treatment, patients get benefits similar to the Kegel exercises, and it focuses to correct muscles without any effort from the patient. This alternative strengthens and tones the sphincter and pelvic floor muscles and improves the patient's muscle awareness. Possible side effects include vaginal irritation, occasional episodes of pain, tide, vaginal infection, urinary tract infection, and local reaction to electrode help. Electrical stimulation is contraindicated when the patient has at least one of these conditions: complete denervation of pelvic floor, dementia, pacemaker, unstable or serious cardiac arrhythmia, pregnancy, active genitourinary tract infection, or seizure disorder. The efficacy has been explored by different studies. For example, one done to 40 patients, out of which 10 had urinary stress incontinence, 15 suffered from urge incontinence, and 15 suffered from mixed incontinence. A total of 25 patients were improved by the treatment, with 8 patients remaining symptom-free for over 6 months. One last study consisted of 359 women with either stress, urge, or mixed urinary incontinence. They were treated with a stimulation for 20 to 30 minutes per day, 5 days a week for 10 weeks. The study demonstrated an overall cure rate of 63.5%, an improvement rate of 15.6%, a satisfaction rate for 83.6%, and only 1.4% of patients described pain at the highest stimulation intensities. So with this evidence, we can conclude that this method has a lot of advantages in terms of social and psychological consequences and quality of life. Medications are the second-line treatment. There are mostly two groups, antimuscarinic and miravigrone. Antimuscarinics are the most common pharmacotherapy for overreactive bladder. Their mechanism of action is blocking the receptors and stopping the contraction of the bladder. However, the systemic blockage of muscarinic receptors can lead to bothersome side effects, including dry mouth, constipation, and headache. Miravigrone has lower side effects compared to them. It has also been shown to have higher persistent rates compared to antimuscarinics. In one study, patients using miravigrone were more likely to continue the treatment than the ones with antimuscarinics. Data from a US survey suggested that the most common reasons for discontinuation of antimuscarinics were that the patients were not seeing expected results, used another medication, coped without medication, the side effects, the costs, and the unwillingness to take long-term treatment. Mirabegron provides an alternative treatment with the potential to increase persistence and has important consideration for managing chronic conditions and for payers when considering economic solutions. Another point in the presentation is third-line treatment. In cases where the first and second treatment lines fails or the side effects are too substantial to continue with the treatment, we move to the third treatment. The third line includes two possible treatments: first, botulinum injections to the bladder, and second, electrical neuron stimulation. First, I am going to explain the Botox injections to the bladder. Botulinum toxin is a powerful neurotoxin as it selectively blocks presynaptic release of acetylcholine from nerve endings. This reduces contractility and causes a temporary degree of paralysis. This toxin has been used in the medical field for many years, most commonly in cosmetic treatments. To treat overreactive bladder, it is administered by injection into certain areas of the bladder using a cystoscope. The injection is made in 20 places at level of posterior wall of the bladder above the trigone. The recommended dose ranges from 100 to 300 units. In the following slide, I am going to explain the basics of nerve stimulation and how the nervous system controls the bladder. Electric nerve stimulation is another third-line treatment for urinary incontinence, and it consists of providing electrical stimulus nerves leading to the bladder. It includes posterior tibial nerve stimulation and sacral nerve stimulation. So to understand how nervous stimulus can help in urinary incontinence, we need to analyze first the nervous control of the bladder. The filling and emptying of the bladder are organized by three centers along the central nervous system that act with peripheral nerves. First, we have the sympathetic nervous system that regulates the process of urine storage. Then we have the parasympathetic nervous system that controls the bladder's contractions and passage of urine. And the third one is the somatic efferent system that permits voluntary control over the external periothecal sphincter. The brain controls the muscle in the body and movements through electrical messages carried by nerves. One big route of nerves runs from the brain to the sacral area. Muscles in the pelvic area are controlled by the brain through these nerves, so the main objective of most electrical stimulation is to attack this sacral area and correct the messages that are sent along these nerves. Electrical stimulation may either make the muscles contract and therefore strengthen, or encourage the growth of nerve cells, causing the muscles to contract. There are three types: vaginal electrical stimulation, as we mentioned above, posterior tibial nerve stimulation, and sacral nerve stimulation. First, I am going to go over the posterior tibial nerve stimulation. It is a minimally invasive option that does not require surgical intervention and can be used in patients with overreactive bladder and urge incontinence. It is a neuromodulation therapy that delivers harmless electrical impulses to the nerves. The stimulation is done by placing a thin electrode or needle in the skin of the lower leg near the tibial nerve, as we can see in the picture. The electrode is connected to an electrical stimulator outside the body and sends pulses. This nerve is connected to the nerve in the lower back, the sacral nerve, that controls the bladder. So in this way, the stimulation blocks the nerve signals that are not working effectively and helps to gradually change the activity of the bladder and reduce incontinence. The treatment takes 30 minutes and it consists of 12 sessions once a week, although some patients may require longer treatments. The stimulus goes from 0 to 20 milliamperes with a fixed pulse of 2000 microseconds at a frequency of 20 Hz. The patient usually feels a pulsing or vibrating sensation around the leg or foot during the procedure, but never painful. There are some side effects that are rare and not worrying, such as bruises or bleeding where the needle is inserted. These effects are typically resolved quickly and don't need any future treatment. Some contraindications include having a pacemaker, bleeding disorders, tibial nerve damage, pregnancy, or severe lower extremity edema. Most patients report symptom improvement within the first 6 weeks of the treatment, but it can take up to 12 weeks to see results. One study showed that over 50% of the patients did not require pharmacotherapy, a decline of urgency, frequency, incontinence, and nocturnia, and a significant reduction in costs. The last treatment option that I am going to explain today is the sacral nerve stimulation. Sacral nerve stimulation consists of installing an electrical stimulator, sort of a pacemaker, under general anesthesia. As we can see in the picture, it is placed under the skin above the buttocks. It is attached to electrodes that send pulses to the sacral nerve located in the lower back. This nerve carries signals between the bladder, spinal cord, and brain, and takes part in the bladder storage and emptying. As it is a complex procedure, it is divided into 2 stages: evaluation and implant. The first stage is performed by placing a thin wire close to the sacral nerve, through a small cut in the lower back. The wire is connected to a stimulator outside the body that the patient will need to wear for up to 3 weeks. If the treatment has positive results and the symptoms get better, implantation of the device will take place. The device comes with a handheld programmer to adjust the level of stimulation. So the optimal frequency of these pulses is above 10 Hz. Some side effects caused by SNS include pain, wire movement, infection, temporary electrical shock-like feeling, and bleeding at implant place. Up to 2/3 of patients will need another surgery within 5 years to fix the implant or replace the battery. Some contraindications of using this treatment include pregnancy or nervous system diseases such as multiple sclerosis. Some studies have shown good results for the SNS with an improvement in the symptoms. In one study, all patients reported improvement results by at least 75%. Long-term results have been explored, with 70% showing a 50% reduction in incontinence episode after 1.5 years, and 59% showed a 50% reduction after 3 years. Another study showed 83% success rate and sustainability 18 months after implant. So in conclusion, while urinary incontinence is a common morbidity with substantial cost, different treatments exist. While in the past, first-line and second-line treatment were used, some of them, such as medication, have substantial side effects. The use of electric stimulation have shown good efficacy and few possible side effects, so treatments such as vaginal electrical stimulation, posterior tibial nerve stimulation, or sacral nerve stimulation are good options to treat this disorder. Scanning the following QR code, you will find the references that were used in this paper and presentation. I hope you find this video interesting and made clear all the information about the use of electrical stimulation for urinary incontinence. Thank you so much for watching the video and listening my speech. And thank you SciTech Central Conferences once again for the opportunity. Please do not hesitate to contact me for any questions or clarifications regarding this content.